All right, it's 8 o'clock, so I think we can go ahead and get started. Hello, everyone, and welcome to the LASI-DAD webinar. My name is Sarah Gao, and I am the project administrator for LASI-DAD. Today, I have the pleasure of introducing Dr. Perry Hu and Dr. Anushka Dunkar, who will be presenting on the LASI-DAD venous blood biomarker collection and results from their analyses. Dr. Perry Hu is a geriatrician at the University of California, Los Angeles. He has been involved in LASI and LASI-DAD from the very beginning, playing an integral role in the development of the biomarker collection protocol for both studies, as well as the geriatric assessment in LASI-DAD. Dr. Anushka Dunkar is a project specialist with LASI-DAD. She has been working with the project since November 2022 and was an important contributor to the biomarker collection process, ensuring quality control during fieldwork. With that, I'll hand it off to Perry and Anushka for their presentation.
Thank you so much, Sarah, for introducing us. Good morning, everyone, and good evening to our colleagues who have joined the webinar from India. I am Anushka Dhankar, and like Sarah mentioned, I am the project specialist for the LASI-DAD project, and I've been fortunate to work with this project for almost 3 years now. On behalf of the entire Biomarkers team, it's my privilege to introduce today's session with Dr. Pei-Feng Hu on biomarkers in LASI-DAD. So let me start with defining biomarkers. The National Institute of Health defined biomarkers as characteristics that we can measure objectively and also evaluate as indicators of normal health or biologic processes, disease condition, or pathogenic processes, or to study pharmacologic responses to a therapeutic intervention. For the LASI-DAD study, we collected rich data on multiple biomarkers through geriatric assessment, such as pulse rate, systolic and diastolic blood pressure, weight and height, and audiometry. Other than that, we collected biomarker data through venous blood specimen collection, neuroimaging using MRIs, among others. But for this presentation, we'll be focusing on blood-based biomarkers that form a crucial part of our protocol. LASI-DAD has developed an extensive protocol to study late life cognition and aging among older adults aged 60 years and above in India. And as part of the biomarker project, we have collected venous blood specimens from our respondents. And we will be talking about our Wave 2 fieldwork operations for blood collection, processing, and shipment. And Dr. Hu will discuss the whole blood and serum-based assays, and we are excited to share some of the findings from our Wave 2 data. In Wave 2, we conducted an extensive field operation across 22 states and union territories of India. Metropolis Healthcare Limited is our collaborating lab partner. They have an extensive network of laboratories across India. And with their help, we were able to successfully complete community-based venous blood specimen collection in India. LASI-DAD field operations, they were conducted in 3 phases. And during each phase, we trained 1 phlebotomist per state. And during the entire field work, we took care of 4 things, which Dr. Hu also agrees with. They are very important, which is respondent safety, informed consent, confidentiality, and standardization. Each respondent was given a unique barcode, which was the only way to label specimens on the vacutainers. We collected about 17 ml of fasting blood samples, but in case the respondents could not fast, we still collected their venous blood specimen and recorded their non-fasting status. We used a vacuum aspiration technique for blood collection and use serum separation tubes, EDTs for whole blood, and plasma preparation tubes. For quality checks, we actively monitored field operations, and all the phlebotomists were certified by us to ensure that the protocol is carried out as per our SOPs. We monitored cold chain temperature for each shipment using factory calibrated temperature loggers. The temperature loggers were checked fortnightly, but sample receiving temperatures were checked as the shipment arrived at the central laboratory in Delhi. We also tracked each shipment with timestamps at multiple checkpoints, And sample centrifugation, for example, was done within 2 hours of reaching the local lab. And within 6 hours of centrifugation, all the samples were shipped to the central laboratory in Delhi. Assays were run centrally with daily QC samples as per NABL standards. NABL stands for National Accreditation for Board for Testing and Calibration Laboratories. All the routine assays were performed within 8 hours, and specialized tests were performed within 24 hours of receiving the samples. So on this slide, you can see the entire workflow of how the samples moved, various checkpoints, and the shipment process. So on the top left, we begin with collecting venous blood specimen from a respondent who consented to participate. Right after collecting the samples from the first respondent, the temperature logger is switched on and placed with the samples in the cold chain shipment to record the temperature throughout. The samples were either shipped to the local lab within 4 hours of collection, or we centrifuged them on site in case of remote areas where our local labs were more than 2 hours away from the collection site. And these samples were shipped to the central lab in Delhi as soon as they reached the local lab. For those where our local labs were nearby, they were shipped within 6 hours of centrifugation. So as we moved on, within 24 hours of being shipped from the local lab, the samples were assayed at the central lab in Delhi. During each checkpoint, we replaced the gel packs. For example, before the samples were shipped to the local lab, after centrifugation, and before they were shipped to the central lab as well. Once the samples reached the central lab, we switched off the temperature logger towards the rightmost corner, and the research team monitored all the logger data for any discrepancies in cold chain temperatures. We are happy to share that we had a 71.3% response rate, and we were able to collect about 3,250 blood samples from across India. Our QC measures are also within the benchmarks, especially when we are conducting community-based sample collection in a community, in a country with diverse geographical terrains, which extends from snowy mountains in the north to scorching heat in the west and the south. And our median duration from processing at the local laboratories, from collection to the processing at the local laboratories was 2 hours, 47 minutes, and the benchmark was 4 hours. Median shipment from local labs to Delhi was 20 hours, and the benchmark was 24 hours. Our median cold chain temperature was 6.1 degrees Celsius, and the benchmark was between 2 to 8 degrees Celsius. And we are happy to announce that our samples had a low hemolysis rate of 6.7%. And if you want to know more about the entire detailed methodology, this is the reference for our methodology paper that we have recently published. And you can go through it and suggest any changes that you would like for us to include for wave 3. And at this point, I would like to hand over to Dr. P. Feng Hu, who will talk about the venous blood-based assays conducted in LASI-DAD, their clinical implications, and some of our wave 2 findings. Thank you so much.
Thank you, Anushka. Can I have next slide, please? So next, I will go over the list of venous blood-based assays that LASI-DAD implemented, their clinical significance, and how they're related to some of the underlying causes for cognitive decline and dementia. So on this slide, let me start with the 2 assays done on whole blood specimens, which are complete blood cell counts, or CBC, and glycosylated hemoglobin, or HbA1c. With CBC, you can get white blood cell counts and differentials. What we mean by differentials are neutrophils, lymphocytes, and monocytes. You can get hemoglobin and hematocrit, which are used to diagnose anemia. You can also get the usual parameters for red blood cell characteristics, such as something called MCV, or mean corpuscular volume, which is a measure of average size of red blood cells. So with CBC results, you can not only make the diagnosis of anemia, you can also determine whether or not the anemia is microcytic, small red blood cells, or macrocytic, which means large red blood cell size, based on hemoglobin and MCV values. And of course, you can also get platelet counts from CBC. Now, HbA1c is a measure of average glucose or sugar level over the previous 3 months. Clinically, it may be used to diagnose diabetes if HbA1c is 6.5% or above, and it does not require fasting specimens since it is an average of sugar level over the previous 3 months. Now let's move on to the serum-based assays, which are on the right side of this slide. You will see glucose values in wave 2 biomarker data set, but they were estimated values from HbA1c levels, not from direct measurement. So glucose levels should not be used to diagnose diabetes beyond what you're able to do with HbA1c. So this is something to be aware of. Lipid panel includes total cholesterol, HDL cholesterol, LDL cholesterol, and triglyceride. And lipoprotein A is a type of low density or LDL cholesterol that have been shown to be a risk factor for atherosclerosis and related diseases, such as coronary artery disease and stroke. As you're well aware, C-reactive protein is a marker of inflammation. It is often significantly elevated in the setting of acute infection or inflammation. The values may be above 10, above 20, or even much higher than that. But chronic, but the lower level of inflammation has been shown to be associated with cardiovascular disease and metabolic syndrome. The next marker, pro-B-type nitrouretic peptide, or pro-BNP, is used for screening and diagnosis of acute congestive heart failure. It is typically increased in patients with either asymptomatic or symptomatic left heart or left ventricular dysfunction. Metabolic syndrome, you see calcium levels, you see measures of liver functions, such as liver enzymes, ALT, AST, as well as albumin, which is a reflection of synthetic function of the liver. You also get measures of kidney function, such as blood urea, nitrogen, BUN, and creatinine. LASI-DAD also measured cystatin C, which is available in our data set. It is a kidney function measure similar to creatinine, but is less influenced by muscle mass. Uric acid is a breakdown product from purines, so it is abnormally elevated in gout. But elevated uric acid is also associated with cardiovascular diseases or risk factors for cardiovascular diseases. Homocysteine is an amino acid. High homocysteine level in the blood is regarded as a marker for cardiovascular disease. Now, we, in our body, vitamin B12, vitamin B6, and folic acid break down homocysteine to generate other chemicals that our body uses. So it may be a more sensitive marker for vitamin B12 and folate deficiency than vitamin B12 and folate levels themselves for those patients who had borderline deficiency. So we do have B12, we do have folate. These or deficiency of B12 and folate may cause anemia. And together with hypothyroidism, they are the reversible causes for neurological problems, including dementia. Therefore, measuring levels of B12, folate, and TSH have been part of the clinical workup for dementia. I'm sure you're very familiar with vitamin D levels. It is important for intestinal absorption of calcium and phosphate and has other biological functions as well. It is related to bone health, cancer risk based on observational studies, and diabetes and cognitive health. In LASI-DAD Wave 2, but not in Wave 1, we've also measured iron metabolism, including ferritin, which is a measure of iron storage in the body, iron levels, and iron binding capacity. So with Wave 2 data, you can not only diagnose anemia, but also looking into some of the common causes for anemia, such as iron deficiency, vitamin B12 deficiency, folic acid deficiency, as well as kidney disease, which is another potential cause for anemia. And the last set of biomarkers were tested on plasma specimens and are more directly related to Alzheimer's disease and related dementia, ADRD. As you know, the pathological features for Alzheimer's disease are characterized by beta amyloid deposit in the brain and formation of neuritic plaques and presence of neurofibrillary tangles composed of tau proteins. And these pathological alterations parallel the progression of cognitive impairment. So for LASI-DAD, we have measured beta amyloid 42 and 40. Typically, we use the ratio of these two. Glial fibrillary acidic protein, or GFAP, is a marker of abnormal activation and proliferation of astrocytes in the brain due to neuronal damage. The last one, neurofilament light, is a marker of axonal damage, basically the long process of neuron axon. So GFAP and NFL levels increase not only in Alzheimer's disease, but neuronal damage due to other causes, such as stroke and trauma. Can I have a next slide, please? So in summary, LASI-DAD has provided biomarker data on many underlying causes of cognitive decline and dementia, such as neurodegeneration, vascular etiology, metabolic and nutritional causes, and anemia. Some of these conditions are completely modifiable or treatable, while others are less so. And these objective measures may be used to define health risk factors, define health outcomes, estimate disease prevalences or incidences, examine disease trend, and provide supporting evidence for health policy decisions. And for the next 3 slides, I'm going to present some of the basic statistics from LASI-DAD Wave 2 biomarker data. So if you look at anemia, essentially half of the respondents had anemia, which is defined as hemoglobin level less than 13 milligram per deciliter in male and less than 12 milligram per deciliter in female. Of those who were anemic, about 64% were due to nutritional factors, defined as concurrent presence of deficiency in iron or B12 or folate. And the rest, about the third, were due to non-nutritional causes. And if you look at cardiovascular risk factor, 5.5% had at risk or elevated pro-BNP. We used age-specific cutoff, which is greater than 900 picogram per liter for those aged 60 to 60, sorry, from 60 to 74, and greater than 1800 picogram per ml for those aged 75 and older. And 72% had elevated homocysteine level, which is actually higher than I expected. Next slide, please. So for metabolic risk factors, 23% had HbA1c in the range of diabetes, and about 40% had at risk or low HDL cholesterol or elevated lipoprotein A level. And among inflammatory biomarkers, 35 or a third of the respondents had elevated CRP level, which we used the cutoff of above 3. Albumin level is also listed here because it is not only just a nutritional marker, but also a negative acute phase reactant. What we mean by that is in the setting of acute inflammation or infection, levels of positive acute phase reactants such as C-reactive protein goes up and the level of albumin go down. Next slide, please. This slide shows the association between select cardiometabolic risk factor and cognitive impairment, which are the 3 column numbers on the left, and mortality, which are on the right. As expected, hypertension, overweight, diabetes, and elevated uric acid levels were associated with both subsequent cognitive decline and mortality. So let me use diabetes as an example. For subsequent cognitive decline between wave 1 and wave 2, the odds ratio for diabetes is 1.19 with a 95% confidence interval from 1.01 to 1.23. And for elevated pro-BNP, which is indicated for heart failure, elevated CRP, and elevated white blood cell counts, they were associated with mortality only, but not subsequent cognitive decline. So I will yield back to Anushka, who will discuss how to get access to our biomarker data.
Thank you, Dr. Hu. For anyone who is interested to download the data and work on it and look at it, analyze it, you can simply visit our LASI-DAD website, which is LASI-DAD.org. And on the rightmost corner, you see a tab of data, and you can click on it. You will be able to get the longitudinal biomarker data, which is available for download in version B.1. And the AD or ADRD biomarker data will be released this fall in October or November. When you reach the LASI-DAD website and click on data, here you'll get the instructions for data download, where you can find the data as well as the code books. The entire instruction on how you can access data is available on our website. You can simply register on the Gateway to Global Aging Data website and sign in the data use agreement, which is completely free of charge. And once you download data, you will find step-by-step download instructions. For any questions, you can reach out to us. And you may also look at our first webinar, which was presented by Sandy Change about how to download data and data files as well as code books. And LASI-DAD is the first study and only nationally representative study on late life cognition and dementia in India. It's a part of NIH's Harmonized Cognitive Assessment Protocol and Alzheimer's Disease Sequencing Program. The project is funded by U.S. National Institute on Aging and Gates Venture. We thank our funders and all our collaborating partners and the entire LASI-DAD team. Thank you so much.
And thank you all very much for your attention. If there are any questions, we're more than happy to answer. Okay, if there are not, Sarah, are we ending this?
Yeah, I guess if we have no questions, then we can wrap up a little bit early. Thank you all for attending the webinar today. Our next webinar will be on November 6th at the same time, where Dr. Nick Reed from New York University will be presenting on the audiometry and hearing data. So again, if you have any questions or would like additional information about the study, please feel free to visit our website at LASI-DAD.org. But yeah, other than that, thank you very much again, and I hope you all have a great day or evening.